address the piezosurgery, a new technology that is at the hand of the practitioners in surgery, not only in cleaning and scaling, but also in surgery, that can cut the bone, preserve the soft tissue, or cut the soft tissue and preserve the bone. And with that, we have Dr. Carine Tabarani, who is a highly skilled consultant, oral surgeon, and implantologist with extensive expertise in oral surgery and implant dentistry and bone regeneration. She is in Abu Dhabi and holds a Master Diploma of Oral Surgery in Implantology from St. Joseph University and has been actively involved in academic research. Currently, she is a visiting professor at Lyon University in France, National Institute for Cancer Studies. Dr. Carine has also served as a senior lecturer in topographical anatomy at the St. Joseph University. Her professional affiliation span globally, including memberships with the American Association of Oral and Maxillofacial Surgeons, International Association of Oral and Maxillofacial Surgeons, and many other associations. She has a strong background in implantology, laser dentistry, platelet-rich fibrin and oral surgery, and piezo surgery. She is committed also to advancing oral health and implantology throughout innovation and expertise. Carine, most welcome. She is from Lebanon. She is working in Abu Dhabi, and she will be discussing piezo surgery. Piezo is not very new. It's from the early ages of electricity, but its application started with Verciolutti in dentistry, in dental surgery, because in dentistry it was way before that. So what is your experience, and how frequent is your use of piezo surgery in oral surgery?
Hello, Dr. Nadim. Hello, everyone. This is a very good question. You know, when I graduated in 2007 from St. Joseph University, we were back then conducting, I'm old. We were back then conducting.
We don't talk years. I never cited any years.
So we were back then conducting some research on the preparation of sites for implants and on the ridge splitting technique using piezoelectric device. This was the first introduction of the piezo in this institute, and since then it started evolving. There's lots of devices in the market, and since then I started using it daily in my practice, and it's impacting. We will see now how it's impacting and helping us with our case day by day.
The screen is yours to explain to us how piezo surgery, oral surgery.
Thank you. It's a pleasure to be with you today to discuss one of my favorite topics and the most famous topic in dentistry and oral surgery, the piezoelectric device. So in the past few years, I was traveling around, exchanging expertise with big names in the field of dentistry. And you can see Dr. Nadim here. And we were discussing how it was impacting and revolutionizing dentistry and affecting the outcome of our practice. So today I will be focusing on bridging science with clinical practice by exposing some challenging clinical cases while assessing each case dependent on the scenario. So first, let's kick off with a brief introduction. What is piezoelectric devices? So it's an electrical energy that is transformed into a mechanical vibration. It was used in medicine first, and then it is now common in dentistry since years. How does it work? So it's a quartz or ceramic crystal that vibrates under electrical current with high-frequency ultrasonic vibration that will give us a control and precise cutting with minimal heat. What we are concerned about is the cavitation effect. So as long as the device is giving us this effect of cavitation, which is an increased static pressure that will cause repeated implosion, bone wearing with blood-free surgical field, which means a more effective surgery and a better outcome by cooling solution and oscillating tip. The advantages are very well known. So we have less trauma because we're conserving the soft tissue and the anatomical structure. We have improved healing because we do not have irreversible thermal damage to the bone. We have enhanced precision because it's selective and precise cutting. We have reduced bleeding. Patient comfort is the most important part of it. Versatility, lower risk of infection because we have a better healing. So how do we use it? I'm going to divide this session into different parts. I will be focusing mostly on the oral surgery. So how do we use it as surgeon in oral surgery? So what do we need from piezoelectric device? We need high precision and safety. So when we are cutting the bone, we are conserving the soft tissue and the anatomical structure. We have reduced heat and trauma. We have user-friendly, versatile application, durability, and reliability. So as we saw previously, the most important part is that we have less risk of infection and an enhancement of the healing in the area because we have less heat generation and more bone preservation, as we can see in the sinus lift. So in oral surgery, we can divide it as follows. I will be elaborating mostly on the sinus lift, and I will be showing you some cases for tooth extraction, bone grafting, ridge augmentation, ridge splitting technique, implant site preparation, apicectomies, and osteotomies. So in tooth extraction, this is a case of a patient that came to me. She had a mesiodens that was resorbing the root palatally of the central. So we had a slight mobility. We had to extract the central and remove the mesiodens. So the machine was already new. I was using back then the NSK VarioSurge, and it was new in the market. So I was really curious about using it. And it was very satisfying experience because the mesiodens was removed. And as you can see with an opening of flap, there is not much bleeding and the cutting is very minimal. So no heat generation, and it was more comfortable for the patient. And the healing was amazing because we grafted the side and we placed immediate implants. In the extraction, I personally use it rarely in the extraction of impacted wisdoms, except if I have cases where they are a really contact with the lower alveolar nerve. It is real, it will take some time, but the outcome is really satisfying. In bone graft and site preparation, as we all know that when we are preparing a site to receive a bone graft, we are perforating the site. I do it 99% of the cases in order to enhance the occurrence of parasites, which are the cells that will enhance the bone healing, and therefore more stabilization and better healing for the bone graft. In this case, I specially use the NSK SG15A that is also used for implant preparation tip to perforate the bone. And I use, usually when I do ridge splitting technique, the SG2L and the SG8L. This is a case that we're publishing now with Dr. Fawzi Riashi from Lebanon, from the St. Joseph University, where we did an external sinus lift simultaneous with two allografts. So we splitted the allograft into two parts and we fixed it in the area with the external sinus lift. What about another application of the piezoelectric device? It is also used in the implant removal. I use it like one case per week where we have an implant removal, unfortunately. And like this case, the patient came to me She had a severe peri-implantitis, pain, pus, swelling. We had to give her antibiotic, and then she had to come back to remove the implant. And as you can see, when I reflected the flap, there is no bone buccally. There was bone mesially, distally, and palatally. So in order to keep this palatal plate, I had to use the piezo and remove it. And graft the bone afterwards. We did a non-labor graft from the ramus, and it was a very successful case. Implant removal, also another case. You can see the minimal amount of bone that is removed using piezoelectric device. Another case of implant removal, why I have a fracture of the implant neck and I had to remove it. I will show you why the piezo is really useful in these cases. As you can see, the impression of the implant threads inside the bone, which means we conserved the bone practically 90% in the area, and this will enhance the healing later on. Osteotomy. Most of us prefer using the conventional way, like the straight handpiece with the diamond round burr to do an osteotomy. We think like, let's be fast, but trust me, in these cases, even the osteotomy in order to access a cyst is very efficient using piezo, because what do we need when doing an enucleation is to conserve this entity, this sample, to do histopathology and also to enhance the healing. In this case, I had to remove this radicular cyst on a lateral tooth, and you can see the blood is very minimal in the field, and I did a bone graft immediately. Another case for a patient that was 13 years old, and his father was wanted a very conservative surgery, and I suggested using piezoelectric device and SK variosurge with the insert that is specific for the case, where it had less vibration, so it was a pleasant experience for a child. And we did an extraction of the impacted teeth and an enucleation of the follicular cyst in the area. What about apicectomy? So usually when you cannot extract the tooth, or you don't want to extract the tooth because it's not indicated, or when you want to have an optimal healing in the area, it is really recommended to use the piezo. Here I did a Lübke-Oschen's-Bein incision away from the crowns because we need to conserve the crowns, and then I accessed the cyst using the piezo. And as you can see, I used also after the enucleation the piezo in preparing the apex to place in a mineral tear oxide aggregate, or MTA. What about another application, which is not very familiar with some, the bone lid technique with extraction? So here we use the SG17 and SG8A. As you can see, in this case, we had an impacted premolar in the area, and we had a nerve. We have the mental nerve. We have also the soft tissues. So we needed to extract. This is a case done by Dr. Riashi and the team, and we published it in 2022. And you can see here we had to access the area using a bone lid technique, and we extracted the impacted tooth and we placed a hemosponge. And then, as you can see, the most and the utmost advantage of this technique is we can place back the bone lid without any fixation. We did not fix it back, so we didn't need any fixation plates or screws. It just fit in and it was very stable. And then we conserved the anatomical structure, the mental nerve, and the soft tissue. And this is the final result with 2 implants placed in the area. And it was published by us in 2022. Another application, I will come back to the sinus lift and elaborate on this topic. I will just pass by really quick on the oral hygiene and some other application of the piezo. In the oral hygiene, we are using it especially because it is efficient. We have precise calculus removal. We have reduced patient discomfort, so the patient is very comfortable with it. less sensitivity because we have less vibration, minimal invasive and gentle on soft tissue, especially if we have to go underneath the gum in some cases, and I'm going to show it to you. We have effective biofilm and bacterial removal. It is safer for the implant maintenance and improve access to the hard to reach areas. This is why it is less fatigue to the dental professional, because we have lots of inserts to be used for each and every case if we want an optimized result. So in the scaling, we have a wide range of scalars, especially in the NSK, from G1 to G13 for each surface and each sextant of the teeth. When we want to go for a perio case, an advanced periodontitis, we also have inserts for them dependent on the sextant and the sides. So we have from P1 going to P1L, and this is why it is very accurate, and we are ensuring that there is a total cleaning of the plaque and the calculus in the area. Also, there is for the implant maintenance some inserts that are also efficient. So a publication by Chang shows that it is really recommended in order to have a maintenance of the implant is to use titanium scaler with powder jet using soft powder in order to lower the bacteremia in the area. So there's the VarioSurge 970 that I used to use that have also many inserts for prosthetic use, restorative, implant maintenance. The idea is to have maximum patient comfort with efficient cleaning and maintenance of the implant. So it is not just placing the implant that is efficient, and I use some cases where I prepared the site of the implant using piezoelectric device, but I know deeply that we're going to come back for a maintenance 6 months after in order to maintain the result that we have. Another application of the piezoelectric device is the restorative dentistry. So it is used especially in sensitive patients. We have cavity preparation, crown and bridge preparation. We have removal of old restorations. It generates less heat, and this will help not to irritate the pulp. The consideration, of course, it's slower than traditional ways, especially if you have large cavities. But trust me, in sensitive patient or when you are close to the pulp, it is very efficient. So it's compatible tips for different procedure, as you can see. Another application is in endodontics. So it is very efficient in endodontics because you can remove the foreign material from the canal, and it enlarges and clean by the cavitation effect the canal. So this is why we have less bacteria in the area and more successful root canal treatment. Now I will start my favorite part of the story, which is the external sinus lift. I personally use a lot the piezoelectric device in the external sinus lift because of, I will show you the advantages, because it is very efficient, it is fast, and I can see properly. The manipulation is very well. And when you have like these cases, now there is lots of people that will say, oh, I use internal sinus lift, I prefer. It is not always indicated the internal sinus lift. Like this case, we have 0.9 millimeter remaining bone. So for sure, it is not a case of a simultaneous implant placement or an internal sinus lift. It is a typical external sinus lift with lateral access and using of the piezoelectric device. So as we all know, after the extraction, I will go quick on this, we have a pneumatization of the sinus, and therefore we have a alternation of the placement of our implant in the ideal 3D position because of this pneumatization. So in this case, as per Rogobar in 2019, showing that the maxillary sinus floor elevation is a predictable procedure, especially using the piezoelectric device. The consideration that we need to look at is not only like we're just looking at the x-ray and we're saying, oh, we have this amount. No, there is more advanced thing to look at. We need to see the Schneiderian membrane. Is there any pathologies in it? We need to see the antral vessel. Is it there to limit the hemorrhagia? And this is the advantage of the piezoelectric device. where when you do the external sinus lift and you do the lateral axis, it will not cut the vessel. You will be able very well to see it. And this is how we can proceed either by using laser or cauterization in order to prevent the bleeding and losing the graft in the area. So I like to go always to this classification by New and Wang, where it goes from A to E3. So the more we go to E3, the more it is a complicated sinus elevation due to the underwood septa. This limitation, as we're going to see, it does not exist. It's no more existing in the piezoelectric device because we are able to overcome the underwood septa. And what we need to focus on when you do an external sinus lift is having 1 to 2 millimeter below the window that we're going to open. And it's a very limited opening we're going to see in some clinical cases, just to have a place to receive the bone in the area. Alternatives, of course, there is alternatives, but it depends on the case and the skills of the practitioner. So it can be tilted implants, it can be short implants, it can be also osteotome approach, but as per Klein, this needs 4 millimeter. Today, some are going for 3 or 2, and in some cases, it is really dangerous to go for this if you don't have implant stability. The advantages: it cuts specifically the hard tissues. Ultrasound has a bactericidal effect. Cavitation effect, as explained previously. Preserves the soft tissue. Precise osteotomy. We have less bleeding, less vibration. A publication by Glezal comparing the macro vibration to the micro vibration, you can see how by the bone burr and the bone saw, we have a burning of the bone. So the structure is not straightforward like the micro vibration. So here we conserve the bone and we had a straightforward cutting. The surgical steps. So I usually use the NSK Vario Surge 3. Now there is 4, and can't wait to use it. It's wireless, so it's like the dream of any surgeon. And we start by using SG6D and SG7D to draw the bone window before proceeding to any step. So I always say, I'm going to go this. I really compare the X-ray to the clinical field, and I start by drawing the window in the area. In some cases, in other devices, they would like to go between the Schneiderian membrane and the window to reflect it. I really don't like to interfere with this contact between the Schneiderian membrane and this window. So I usually, it depends. If it goes up by itself, I will just take it, grind it, and using with the bone graft. And in case it is really adherent, I don't want to take the risk and drip the Schneiderian membrane because we are already, it's a risky and very delicate surgery. So I just reflect it inside to become the new roof of the graft. Step 2, I go for a bone window detachment, window reflection using specially the SG11. So as you can see, I go all around to liberate the Schneiderian membrane for the bone insertion. As you can see, so the membrane reflection from bony insertion using the SG11, and you will see here. So I'm liberating it more. It's a very thin Schneiderian membrane. And you can see the rhythmical movement. The rhythmical movement is really witnessing that there is no perforation in the Schneiderian membrane. After that, I just do the elevation from sinus floor and palatal wall, either using the Mills curette or the SG9 or SG10. The important thing to be done over here that we should focus on is that you need to go all the way to the medial wall. Don't stop on the lateral wall, because if you go to the lateral, to halfway, you're doing an uncompleted sinus elevation. And then we check the rhythmical movement like this case. And then we go for a graft, either using xenograft, allograft, or autologous bone graft. I usually, as I said, when I reflect and I see that the bone window is detached, I just go and grind it and mix it. So you can see here we had 0.4 and I gained like 16 millimeter of bone. And this is how, let's see. Then membrane placement, isolation of grafted material from connective tissue invasion. There's lots of publications that are out since years, like Cassetta and Pavlikova, that says that the external sinus lift using piezoelectric device is a reliable technique and will go to 90% of success. So a publication by Scoots that evaluate the intraosseous temperature changing, and it compared the conventional way where you use the rotary to the piezoelectric device, where we had a irreversible terminal damage in the bone when using the conventional way compared to the piezoelectric device. Another publication by Gulnahar that used the heat shock protein 70 expression as a prognosis for surgical marker, and it shows that it is really significantly increasing in immediate post-operative period when you're using conventional technique of rotary. So when should we go for lateral sinus lift using piezoelectric device? We all want for our patient lower morbidity, less complication, lower cost, shorter treatment time, but it's really linked to the anatomical condition that we have and the know-how and clinical skill of the surgeon that will start the surgery. So usually a publication by Agliatella showed that there is 98% of survival rate using a lateral sinus lift using piezo. So when we need a gaining of bone more than 8 to 9 millimeter and the remaining bone is less than 3 millimeter, so this is the case that is an indication for an external sinus lift. Of course, there's some limitation when we have a pathology, enteral pathology inside the sinus, or when we have a sinus disease or closed entronasal foramen, so there is no drainage in the area. So these are considerations that we need to take in mind, to keep in mind, and therefore prevent going to the surgery before treating it. The underwood septa is no more a contraindication because we are able to overcome it using the piezoelectric device. As you can see in this case, it's a classification, typical classification E3 by Wung. Of course, there is some publications that goes with the flow of the piezoelectric device. There is also some that are saying that it works teaming up or synergistically between the piezo and the conventional way, like Atiye and Stachy, and it shows it will give very excellent results. So when should you go for a sinus elevation simultaneous with implant placement? So when we were in college years back, they used to teach us that we need to think about the 5 millimeter rule. So if you have a lateral technique with stage approach, it depends if it's less than 5 or more than 5. And today this changed because of the anatomy and because of the shapes of the implant and the surfaces, and because of the technique and devices that you are using. Like this case. So whenever we can go for an implant stability that is optimized and in a predictable way, like 3 millimeter crest height, even sometimes 2.5, we can go for a simultaneous implant placement. Oscar in 2018 showed that the external sinus lift using piezoelectric device with simultaneous implant placement, especially when you have a bone height of 4.27, will give reliable and excellent outcomes. So there's clinical success criteria that we need to look into it, like absence of Schneiderian membrane perforation, absence of benign vertigo, less invasiveness, less bleeding, patient comfort, no local inflammation, absence of loss of graft material, which is the essential part, reduced time for implant placement with minimal size lateral access. As you saw in all the cases that I showed you so far, we have a very limited access. And bone stability with predictable and reliable results, satisfactory keratinized tissue, because when you have a good bone, also you're going to go for a good gum surrounding the area for the bone graft, so no prosthetic complication. Absence of Schneiderian membrane perforation. So Barbu showed that 6 to 10% there is risk of perforation by conventional way, which is reduced with piezoelectric devices. Chow also showed that there is some risk, like the underwood septa, tapering sinuses, or narrow tapered in the area. Toscano showed that 0 perforation using piezoelectric devices and 2 using hand instrument over 56 patients. And this is a publication that is in 2010. What do you do when you have a perforation? I'm in the field since 2007, and I think that there is no perforation that we're not prepared for. Most of the cases, and I will show you some cases, when you have a perforation on the cuts on the CBCT, you're going to see that there will be a perforation. And usually in these cases, I prepare a 5-0 to 6-0 resorbable stitches, and I prepare the PRF. Like this case, when you have perforation, you just place the PRF and a cross-link, a non-cross-link collagen membrane, and then you continue the sinus elevation. So the PRF is used as a scaffold associated to cross-link collagen membrane, and in some case I put a non-cross collagen membrane inside to in the perforation of Schneiderian membrane. But what if we don't have enough bone support for implant? And this is something that I see some people doing. Unfortunately, I had a case last week where it was referred to me to remove an implant from the sinus because they tried to minimize the treatment and do the sinus elevation internally, so indirect, and place the implant. But there was no sufficient bone to have this implant stability, and it ended up inside the sinus. Radiographic parameters for the success, we need to compare the preoperative and the postoperative bone height, stable graft bone material, crown to implant ratio, marginal bone loss, we evaluated after 1 year of implant placement. It should be stable. Absence of chronic sinusitis. This is a case where it was placed 3 SP 4.1 per 10 Stroman implants. The ridge height was 2.9 and the bone gain was 10.2 millimeters. Let's start with some clinical cases. So usually, before I start the external sinus lift, what I do is I take a CBCT, I discuss the risk factor with the patient, and I give antiviral prophylaxis, 2 grams of amoxicillin if the patient is not allergic, 1 hour before, and I start the nasal spray, usually Flixonase or others, minimal steroids, 1 day before. So this is a case of severe atrophy. We had to place a premolar and the molar. The approval was like this, so we had to be committed really to it. So I placed a short implant here, and I had to do an external sinus lift. As you can see, we have a minimal bone height, and I don't think anyone will go and do an indirect sinus elevation with this bone height. So there was a lateral window that is drawn by the piezo, and then I detached it with the SG11 from the NSK inserts, and then with the Mills curette I continued the elevation until I had a total elevation and rhythmical movement of the Schneiderian membrane. Then I grafted with bone. I placed, as you can see here, the premolar, and this site was after 6 months to place the implant in the ideal position. And you can see the bone after eight months later. Let's see the video. And the final results. Another clinical case, I just want to show you the pictures here because it's fascinating how thick was the bone, and we used in this case the piezo. As you can see, it was so thick and adherent to the Schneiderian membrane, so I had to liberate it really. It took some time, but it was very efficient. I had minimal bleeding afterwards, and I reflected, as you can see here, the window up, so it will be the floor of the new sinus and the ceiling of the grafted area. As you can see here, 3 implants were placed bone level with the sinus elevation, and here is the result. Another clinical case, also you can see how it is used daily, and we can go 10 plus implant placement in the area. This is a case of the underwood septa. So I had an E3, a challenging case of E3 classification. So the risk of perforation of the Schneiderian membrane was really high, but I trust my device and the fact that it will overcome it. So I had like really to go very slow and go around it to break it and liberate the insertion of the Schneiderian membrane from the underwood septum, as you can see here. Here's the bone graft afterwards. Another clinical case also where we grafted the bone and placed the implant. As you can see, the opening is very limited with the piezoelectric device. By the conventional way, you cannot access in the same way. You need a big opening, and it's more traumatizing to the patient. Another case also where I had 2.48 millimeter of remaining bone. I had to go and elevate the sinus using the piezoelectric device. The opening was also, it is a very straightforward technique with the piezoelectric device because as you can see, it's repeating itself and it's very predictable. So we know that it will go inside the sinus, it will elevate the Schneiderian membrane, and we do not have any perforation. As you can see, SG11 comes in, elevate the Schneiderian membrane, and release it from the bony insertion, and then an implant was placed. And then the ideal implant placement. Another case, a very advanced bone loss of 1 millimeter, the same way, elevation and implant placement. I want to discuss with you especially this case because, as I said, the CBCT is a very important tool before going to any surgery, especially inside the sinus. First, to evaluate if there is any pathologies or congestion that we need to treat prior to the surgery, and also to see where is the Schneiderian membrane. So in this case, as you can see here, I had this fusion between the periosteum and the Schneiderian membrane. So it was a very delicate and challenging case where I was really prepared for, and I had to discuss the options with the patient. The patient was insisting not to go for a bridge in a conservative way, and lucky me, I had to go inside the surgery. You see, there is no floor of a sinus. I could touch the Schneiderian membrane with my finger through the mucosa. So what we did is a incision. I had to dissect with a Metzenbaum scissor the Schneiderian membrane from the periosteum. Luckily, it was a thick membrane. He was unfortunately a smoker, so I had this small perforated or ripping in the Schneiderian membrane. So as I said previously, since you're prepared for it, you can directly overcome this challenging case by using PRF and 60 stitches resorbable polyglactin 910. So what I do is I stitched the membrane, I elevated it and with the piezo, and then I placed bone graft and I continued normally. As you can see here, usually we say theoretically that we need 1 to 2 millimeter down, but it was really a challenging case. I had here some bone to hold the bone. My only problem was this area of the floor of the sinus. And then we were really pleased by the results, where we placed bone and we placed the implant afterwards. Another case also where we prepared a bone window and reflection of the Schneiderian membrane from the insertion. And as you can see, always the opening is very minimal and a very conservative approach. And then we place the implant.
Carine, would you like to comment on the videos, please?
I don't know if they will be able to hear me, Nadim. Will you hear me clearly? Okay, I would love to.
Because there is no sound on the video. There is no sound on the video.
Okay, the videos has no sound. This is something that, okay, very good, because there is music on the videos, usually. Okay, so I'm gonna, I didn't know there is no sound. Okay, let me just comment then, since there is no sound on it. So good. Good, you told me now, Nadim. So what we do usually is as follows. We are trying here to, with the first insert, to draw the opening and before starting the real elevation. So as you can see, it's a minimal opening. And then with the SG11, we liberate the Schneiderian membrane from the insertion. And then after that, we graft the sinus. We place the implant simultaneously. Another clinical case of advanced bone loss. I think, Nadim, it should have been sharing sounds previously. It's fine now. So another case of advanced bone loss. So you see the atrophy. This is, we're talking about 0.9 of remaining bone. Also, a small drawing of the bony window. You make sure it is free and there is no really insertion of the Schneiderian membrane to the bone. Using the SG11 here, we liberate the area. And then, as you can see, we're still liberating it. And then we start the reflection. You see the movement, the rhythmical movement in the area. This is a very important sign of absence of perforation. And then we start the reflection. I usually alternate here the NSK piezo inserts. And then we have the bone graft. After 6 months, I come back and I place the implants. So today we need an evidence-based practice based on the clinical expertise, evidence, patient preferences. So what we're trying is to have the best science to make decision by having all the quality and judgment with a scientific background in order to make decision while using the piezoelectric device, either in surgery or in restorative or in endodontics or prosthetic. So in conclusion, what we're trying today to do is to integrate simple therapies in everyday practice by bridging science with our daily application, either in the scaling, hygiene, endodontics, periodontal therapies, and especially oral surgery in order to optimize the outcomes. I would like to close with this quote for Grant Cardone: "Your greatness is limited only by the investment you make in yourself, so invest well." And I would like to thank you for your attention.
Thank you, Carine, for this investment that you've done today, and you invested in us by giving us all your knowledge in piezo surgery. We have a couple of questions. If you be kind enough to share your screen, so we'll be able to talk. Yes, we're talking about piezo surgery, or piezo in general. Piezo in general, we can use it for scaling and cleaning. Does the instrument or the machine that you use provide us the option of doing the cleaning and scaling, or is it only limited for surgery?
The VarioSurge can be used because it has lots of, especially the VarioSurge, it's used especially in endo. We have perio and we have surgery. So it uses the three options, but it depends on purchasing the scalers and the inserts for each and every application.
Mm-hmm. Now that you have mentioned endo, how small is the endo inserts, and what is the taper? Do you have any? I know that you're not an endodontist, but this is a question. If you don't have an answer, we'll refer it to the company.
We need to refer it directly, Nadim, to an endodontist. Okay. I just saw the application with my colleagues in the field, but I don't know the insert, how it is the size and everything. But I saw how it's removed, how the application was so easy and very efficient, especially for the removal of materials from the canal. So it was a very efficient way, especially using the NSK insert.
Mm-hmm. Definitely, it's a very important step in endo, where cleansing the canal and final cleaning of all the smear layer from inside the canal is done by ultrasonic endodontic inserts.
True.
Tell me, when you're cutting hard tissue, compared to the rotary instruments, they say that piezo is slower than rotary instruments. How true is this, and what are the advantages for using it?
A very good question, as always, Doctor. Actually, it is slower in some way, but when you are a surgeon, what you're searching for is the outcomes. We're not searching for just if it's slower or no, because once you have the hand and it's like a daily practice, you will make it faster. So you will know we start here. You don't have to guess. You have a good planning. So for me, the piezo, personally, I'm sure there is lots of colleagues that shares the same idea and the same opinion, that with the piezo, for me, it is faster because I have a clean field. I don't have bleeding. I can see well, not like the conventional way. I have bleeding. I cannot see. I have to do suction. I have to stop the bleeding, stop a little bit, then go ahead and continue. With the piezo, it's a very straightforward thing, Dr. Nadim, and therefore we have a clean field that optimize the result and make it a faster way and faster approach for me personally, and I think for lots of my colleagues that share the same opinion.
And definitely heat generation between rotary instruments and piezo. There is no heat and no burning hard tissue.
Yeah, like we saw with the cuts macro and micro vibration, and also by the heat shock protein, the published prognosis that show that it was elevated in the conventional way. So this is definitely a think about approach.
Mm-hmm. Yes, when you move in from the hard tissue to the soft tissue, do you change the mode? Because we used to have a hard tissue mode and a soft tissue mode. Are we now still in one mode that can address both tissues?
Yes, this is also a good question. With the NSK variosurge, Dr. Nadim, what I use for the NSK, it is always the same approach because you have the endo mode, you have the surgery mode. So I'm always in the surgery mode because I am sure with the speed that I am adapting the device to, there won't be any perforation or any alteration of the soft tissue, and it will be efficient on the hard tissue at the same time.
Yes, definitely. You are into surgery mode. In the surgery mode, we have two modes: hard tissue, soft tissue. When you would prepare the window, you prepare the window with the hard tissue mode. When you come with the elephant foot, what you call is SG11. This is what we call the.
I stay on the same mode. No, I stay on the same mode with the variosurge. This is the advantage of variosurge, is that you stay on the same mode. You don't have to change the mode between you stop and you just go ahead and finish the surgery right away.
Mm-hmm. So this is interesting because in the old systems we used to have hard mode,
correct,
soft mode, and the elephant foot is very practical in starting the elevation without tearing the
SG11. Yes.
Tissue. Yeah,
correct.
And when you had this perforation in the Schneiderian membrane in the sinus, did you relieve it more before doing the surgery so you have more elasticity, or you just did the suturing before and then you did the elevation?
Also, great question. When I access, you're happy about it, complimenting you, Dr. Nadim. So, as you might know, that when I start the elevation and I showed the cases, that I release totally the Schneiderian membrane before even having a perforation or anything. So when I have a perforation, I make sure I will stitches and continue the elevation directly. So it's already a free Schneiderian membrane, and then I stitches and I continue the elevation.
Mm-hmm. Interesting. So, how does piezo surgery affect the bone healing dynamics compared to conventional instruments? Rotary.
Yeah, we already mentioned that yes, it will enhance the healing because you don't have irreversible thermal damage, and it is a very short time elevation, so less risk of infection, better healing, and better comfort for the patient. And even I remember when I used to use the conventional way compared to the piezo, we had like more swelling with the conventional way compared to the piezo, because we used to do a big opening with the bone. With the piezo, it's a very minimized one and straightforward technique.
Definitely a small opening for the sinus lift is very indicated to keep all the potential of the healing, because we know that the healing is not coming from the bone does not come from the membrane, but comes from the lateral walls, meaning the buccal wall and the lateral wall, internal wall, that will bring the blood supply for the healing of the sinus. So as minimal as possible as a window is indicated in sinus lift. Can we make a platform on the ridge using the piezo for implant placement? Can you level the ridge if you want to level the ridge for implant placement?
Oh, yes, of course. We can, of course, but I use it minimally in these cases. I use it especially in ridge splitting technique. But for the flattening of the ridges, yes, it can be used easily with the round inserts. Yeah, it's just like the conventional way, but it's like more conservative, less trauma to the bone.
Okay. There are some questions that are related to endo and to perio and cleaning. I think endo, we have to refer it. Ladies and gentlemen, this is a presentation that addresses piezo surgery, not endo. Definitely, endo would be addressed in an endo session. So in surgery, in your opinion, it is very helpful, and it depends on how trained is the practitioner in using this. Cutting teeth, how easy is to cut teeth with the piezo? And do you really need it to cut the tooth, or would you simply cut it with a high speed or any other device?
I personally used it in few cases, around like 25 to 26 cases, in a patient that is very sensitive, like children, very scared the patient that do not want the high speed drills, and it was efficient. It was a little bit slow, I have to say, but we got to where we want, and the patient was pleased, and this is the most important thing. And even when I had to do osteotomy while removing and separating the roots for a wisdom, it was also very conservative, because we didn't have this amount of bleeding, and the patient was really happy with the result.
Have you ever noticed any difference in the post-op incidence on the patients if you use rotary instruments or piezoelectric tips?
During the extraction?
For example, any kind of osteotomy, extraction, sinus lift, you used to use rotary burrs, and now you're using piezo. Have you ever noticed any post-op differences in the swelling and the bleed and the
definitely.
pain?
Definitely, Dr. Nadim. I had the cases where I had to see the patient after 2 days, because he was really scared of the swelling and the bruising that he had after sinus, and this is a long time ago. And this is one of the reasons that made me take the decision to step into piezoelectric devices, because I don't have this swelling, because I don't have this big opening in the area and this big osteotomy. So it's a very conservative way. We don't have bleeding, so we don't have infiltration of the blood in the tissues, and therefore we have a post-op that is optimized.
Okay, and the difference between the tips, you have diamond tips and metal tips. What are the indications of the diamond? What are the indications of the metal one?
The diamond one are always to address the hard bone in the sinus lift, especially. So when I draw the window, or I want to access the area by anyways, or do an extraction, I always use the diamond, because it's very efficient in this part. And when I go for the SG11, which is non-diamond, and this is the elephant shape insert, and it's a metal, I have to go once I am close to the Schneiderian membrane, because it will not really hurt the Schneiderian membrane. It will be very conservative on the soft tissue.
I know that you're at St. Joseph University. You conducted studies on implant placement with piezo surgery, along with Thomas Verciolotti, the one who is behind the piezo surgery. What are the
We were in the team, if you can say. We didn't conduct it personally. They conducted it. We just went along.
What are the results? How slow or quick is the site preparation? Or is there any advantages in bone healing or osseointegration? Do you know any of the study's results?
Yes, the result was really an optimized osseointegration in the area, because and the better stability was obtained, because it is not like an adapted for, like, you want to place a 4.1 implant, you're gonna place an insert 4.1. It was underestimated, so the stability was optimized, and the healing was also excellent. Yes, they had great prognosis for all the implants that were placed. And we're talking 2007, Nadim. Now we are 2025. It really changed and evolved.
Yes, definitely, by all means. Is there any contraindications for patients who have pacemakers?
There is some study that prefers not to go with pacemakers, but nowadays, yes, we're going for it really, and there is no problem. Especially with the new one, it's a really vibration, not a rotatory movement, and no effect on the pacemaker. So we're good now. But it depends the publication pro and against. Who do you want to believe?
Don't forget, now we are in 2025. I'm getting back at you.
You liked it?
Yeah, in the early times, we used to have the mobile phones contraindicated for patients with pacemakers. There is no contraindications. accordingly strict contraindications for patients with pacemakers. But don't put the machine on the pacemaker.
On his heart, yeah.
Thank you, Dr. Carine, for this very interesting overview
My pleasure.
Of this piezo surgery, use of piezo in oral surgery. And we'd like to thank our supporter. Definitely, I'd like to thank all the participants who've been with us and the CAP team for supporting us and giving us all these free webinars. By tonight, you will be receiving an email. And in the email, you will have two things. One, a link for the rerun if you have missed any of the information or if you'd like to review the presentation. And you will have a link to download your certificates. In any case, if you have any unanswered questions, please send us an email at events@capmea.com, and we will be glad to transfer this email to Dr. Carine Tabarani, who will answer you promptly. Thank you very much for all of you. Thank you for our supporter, NSK. Thank you for CAP team. Have a good continuation of your day.
Thank you.